A single miscarriage can be cataclysmic enough, let alone three, one after the other after the other. Traditionally, we define recurrent miscarriage as 3 miscarriages in a row to the same partner. Clinically, recurrent miscarriage is important because it makes us worry that there might be a specific cause for your pregnancy loss. But in real terms, health departments have felt that it's only at this point that it becomes economically feasible to fund the tests in order for us to check and see. This is partly because we know that the vast majority, probably 85% or more, of people who suffer one miscarriage will go on to have a completely normal pregnancy the next time round. But this is where the real conundrum for us clinicians lie. I mean, sure, I understand that tests are expensive, but what am I supposed to do when I'm sitting in the clinic room looking at the whites or often the reds of a couple's eyes who have just found out that there's no heartbeat? Am I really expected to explain to them that they need to go through this 1 or perhaps 2 more times before they're considered even worthy enough to get a few blood tests? And of course, what then? What if we find a reversible cause for the miscarriages, knowing that we could have done something, often something really simple, to have prevented them? Talk about bittersweet, but mainly bitter, I think. The other aspect, of course, is time. We know that fertility declines with age. To go through 3 miscarriages takes precious time away, and that's before we even contemplate the mental toll. There is also a physical toll. Each surgical procedure to empty the uterus runs the risk of scarring the uterine wall, which can affect subsequent pregnancies. And of course, surgical evacuation of the uterus is the best way that we can get a sample and test it to see whether there was any underlying chromosomal anomalies in the fetus. So I think it's best to treat each circumstance individually. If a patient's particularly anxious, if they're getting on in age, if they've had a complicated fertility journey, or if it was one of my 3 daughters, I would have absolutely no compunction in testing early. So what do we look for? I've already mentioned chromosomal studies on the fetus, but we can also check the chromosomal makeup of both parents. We can also look for a variety of medical conditions that can make the blood sticky and thus increase the risk of miscarriage. It's also a good idea for us to get some really high quality imaging of the uterus to see if there's any anatomical anomalies that we can sort out. We also test a variety of organ functions, especially the thyroid. As a result, we may find that something as simple as aspirin, blood thinning medications, or thyroid treatment may be sufficient to fix the problem. Ultimately, while miscarriage is common, and your doctor will no doubt support you through that disappointment, at the heart of it, they never want you or themselves to be in this situation again. You and your doctor will do whatever it takes to one day soon take home a healthy baby from the hospital. And that's what it's really all about.